Hey, good day and welcome to UroNurse News. I'm your host, Vic Senese. Be sure to like and subscribe. Today we're taking a look at a major shift in prostate cancer hormone therapy, one that actually revisits an older hormone strategy with a modern delivery system, transdermal estradiol patches in locally advanced prostate cancer. I'm old enough to remember when we used to give prostate cancer patients the pill to reduce their testosterone. For decades, androgen deprivation therapy, commonly using LHRH agonists, has been the foundation of treatment for locally advanced prostate cancer. But these drugs come with well-known effects: hot flashes, metabolic changes, bone loss, and reduced quality of life. This study revisits an alternative approach using transdermal estradiol patches, or TE2, to suppress testosterone. The concept's straightforward. Estrogen provides negative feedback at the hypothalamic pituitary axis, lowering testosterone production, similar to LHRH therapy, but through a different hormonal pathway. Importantly, transdermal delivery avoids first-pass liver metabolism, reducing some of the thromboembolic risk seen with oral estrogens. This was a large phase 3 non-inferiority randomized trial conducted across 75 centers in the United Kingdom. Between 2007 and 2022, researchers enrolled 1,360 men with locally advanced prostate cancer, including T3 disease in the majority, node-negative and node-positive patients, median age 72. Patients were randomized to either receive transdermal estradiol patches, 100 micrograms daily, or standard LHRH agonist therapy. The primary endpoint was 3 years metastasis-free survival. So, what happened? At 3 years, estradiol patch group, 87.1% had metastasis-free survival. LHRH agonist group, 85.9%. The result? TE2 was not inferior to standardized LHRH therapy. The hazard ratio was 0.96, meeting the statistical threshold for equivalence, meaning that both of them worked as well. In plain terms, estradiol patches performed just as well as standard androgen deprivation therapy in preventing metastasis over 3 years. Both groups achieved similar biochemical suppression. About 85% maintained castrate testosterone levels during the first year in both arms. This confirms that estradiol patches are not just theoretically effective, they achieve the same hormonal endpoint. That's key. At 5 years, estradiol group survival was 81.1%. LHRH group, 79.2%. Again, hazard ratio 0.9 with confidence intervals overlapping equivalence. While not statistically superior, outcomes were comparable and reassuringly similar. Now, here's where things become clinically interesting. Hot flashes. Estradiol patches, 44%. LHRH, 89%. That's twice. That's a dramatic reduction. However, there is a trade-off. Gynecomastia, the patch, 85%. LHRH, 42%. In moderate to severe cases, as high as 37% versus 9% for the LHRH. So while patients may experience fewer vasomotor symptoms, breast tissue effects are significantly higher with estradiol therapy. Importantly, thromboembolic risk was mitigated compared to historical oral estrogen concerns due to the transdermal delivery. That was always the big problem with the pill, is patients were worried that they might throw a clot. So what does this mean for clinical practice? Well, transdermal estradiol patches represent a viable alternative to LHRH agonists and comparable cancer control outcomes with a different but predictable side effect profile. This is not a replacement recommendation for current standards, but a legitimate parallel strategy supported by phase 3 evidence. It may be particularly relevant for patients with metabolic concerns, those struggling with hot flashes, and individuals seeking alternative hormonal approaches under specialist care. In summary, transdermal estradiol patches in locally advanced prostate cancer demonstrate non-inferior metastatic-free survival compared to the standard LHRH agonist, with a distinctly different quality of life profile. especially that hot flash. Some patients with hot flashes are just miserable. As always, this is an evolving area of urologic oncology, and treatment decisions must be individualized. Thanks for watching UroNurse News, and I'm your host, Vic Senese. Now, tomorrow on UroNurse, uronurse.com, we take on one of the most challenging and frequently misunderstood areas in urology and infectious disease practice, complicated urinary tract infection. With new 2025 updates from the IDSA and the EAU, clinicians are being asked to rethink how they approach diagnosis, antimicrobial selection, and treatment pathways in patients with complex infections. In this episode, we're going to break down what's actually changed and what it means at the bedside, how definitions of complicated UTIs are evolving, what the latest guidelines say about antibiotic stewardship, where imaging, cultures, and risk stratification now fit in, and how to navigate resistant organisms in modern practice. This is not just an update, it's a shift towards more precise, evidence-driven infection management. We'll also look at how these changes impact real-world clinical decision-making across inpatient, outpatient, long-term care settings. And hey, most importantly, you get a free credit for watching this episode and taking the follow-up test. So whether it's CME, CNE, CPE, you get one free credit. So it's a good one to take.
UroNurse News every weekday at 9 a.m. Central Time.